Hello my friends, welcome once again. Today we will be talking about hematuria, and in this particular lecture we'll be focusing on how do we differentiate between glomerular and non-glomerular origins of hematuria. So let's begin with the definition. So what is hematuria? Hematuria in very simple word means presence of blood in the urine. So if somebody has got blood in urine, we call it as hematuria. So this could be in the form of called presence of blood in the urine, which you can see with your naked eyes. So if you see that somebody is passing blood in the urine, fresh blood, or maybe the color of urine is changed, you see that it is more pinkish, more reddish, or more dark brownish, tea colored or cola colored. Basically, you are looking at it with your eyes. So that is known as macroscopic hematuria. So macroscopic mean where you can see it with your naked eyes. And how do you see it with your naked eyes? Because you know that the color is pink, or it is red, or it is brown, or tea colored. So if that is the condition, we call it as macroscopic hematuria. The other type of the hematuria is where you can't see it with your naked eyes. The urine, like per se, looks normal, but when you test it, and the test that is usually done is known as the urine dip, which is a bedside test. So that urine dip shows the presence of blood or RBCs, and that is known as microscopic hematuria. So microscopic hematuria means that you cannot see the blood with your naked eyes, but the test, usually that's the bedside urine dip test, that is showing you the presence of what? Blood in the urine sample. So that is hematuria by definition. So it could be macroscopic, it could be microscopic. Now, this blood that is either macroscopic or microscopic, it could be either of the glomerular origin. Glomerulus is one of the what you call the basic structure of the kidney. It's part of the nephron. So if there is a problem with the glomerulus is a basic filtering apparatus unit in the kidney which filters your urine. So normally it shouldn't be filtering blood. The blood doesn't come into the urine sample. But if because of some reason there is damage to the glomerulus, mostly because of inflammation, then the red blood cells would be passing into the urine and you will be getting hematuria. So if that blood is coming because of a problem with glomerulus, so there is some like inflammation or damage to the glomerulus, then that blood is of glomerular origin. Or it could be of non-glomerular. Non-glomerular origin means any other problem. So it could be, let's say, because of coagulation defects. Coagulation defects, like for example, somebody is having hemophilia, or somebody is having von Willebrand deficiency. So coagulation defects, or problems beyond kidney. For example, problems in the ureter. If there is a stone in the ureter which is causing like irritation of the epithelium, and subsequently, blood is seeping into the urine, or there is problem with the urinary bladder, or there is problem with the urethra, anything. So anything which is not related to glomerular, whether it's there in the blood or whether it's beyond the kidney, like problems with the ureter, with the bladder, or with the urethra, we would call it as non-glomerular hematuria. So it's very important that we differentiate, because the treatment differs. So how do we differentiate between that? Let's start with the example of a case study. So here we got a 13-year-old boy. So this 13-year-old boy, he has got some painful lesions on his skin, and somebody dipped his urine and they found out that his urine was showing blood 2 or 3 plus. So it means that he has got microscopic hematuria. Or let's say his blood was dark brown colored. So somebody tested it and it's showing like positive for blood. So he has got hematuria, and he's got a history of these lesions on the skin, and you can see them on the pictures right here on the slide. So if you see this particular lesion, so this is a big lesion, maybe it's there in his armpit, or maybe on the upper arm, and you can see that's a well circumscribed circular lesion with a central area of scabbing, dark scabbing, or eschar formation. So this is dark scab, or we also call it the eschar formation, which is the encrustation eschar formation. And at the side, you can see that there is a peripheral rim of desquamed inflamed area. So you see there is a desquamed because the epithelium has been shed. So desquamed epithelial inflammation, inflamed area, which has got very clear borders here. And this particular lesion, you can see that there is a central area of slight maybe ulceration. It doesn't look like frank ulceration, but obviously there looks to be a bit of inflammation and oozing. So there is a bit of inflammation, possibly oozing. And there is a rim of, again, scabbing or eschar formation, dark scar formation. And you can see that there is the area of inflammation and possibly thickening of the skin here. If you feel it with your fingers, we call it as induration, and it is very painful. So if you touch these areas, the child is complaining of what? Is complaining of pain. Otherwise, he seems well in himself. Excuse me. He seems well in himself. He hasn't got any history of fever or anything else going on, but you see these lesions, and there are probably a few of them on his skin. And the other thing is that he has got blood in his urine, which we call as, by definition, becomes hematuria. So now the question is, coming down to his hematuria, we'll come to the skin lesions later on, but let's talk about hematuria. Whether that's hematuria or that blood in his urine, is it of glomerular origin or a non-glomerular origin? So the question is whether this is glomerular in origin or whether this is non-glomerular in origin. So how do we know if that blood that is present in his urine sample, it is glomerular in origin or not? Now, urine dip simply tells us that it is blood. But to determine whether it is glomerular in origin or non-glomerular in origin, we need to evaluate the urine sediment. In other words, we need to take a sample of this urine sediment, prepare a slide, and look it under the microscope. And that's usually done by an expert. So we call it urine microscopy. So urine microscopy is done. And what we are looking at under the microscope, basically we are looking at if we find any white blood cells, we find any red blood cells, or we find any casts. And these casts could be made up of red blood cells, white blood cells, or amorphous material like calcium oxalates, things like that. So how do we know? Basically, the thing that we need to do is urine microscopy, in which the urine sediment is taken and is examined under the microscope. So what do we see under the microscope? Let me show you. Now here, if you look at, so on the left side, you can see this is basically a photograph taken from what you would see under the microscope. So pictures which have been magnified on the right side. So here in this picture, what you are seeing is like, these circular structures. Some of them are red blood cells, some of them are white blood cells. Now, if you look, some of the red blood cells here are properly circular shaped. So that means that these are normal shaped RBCs. But look at some of the RBCs are squeezed. They are like dysmorphic. They are disformed. Look at this RBC, this RBC, this RBC, okay? Maybe some other one as well, like here, see, this RBC, this RBC, this RBC. Some of them have been disformed. Now, how an RBC could be deformed? Basically, when an RBC passes through the glomerulus, like glomerulus is a tight structure, normally an RBC cannot pass. So if RBC passes through a very narrow tunnel, it gets squeezed, gets deformed, it gets broken down. So if there is a problem with the glomerulus, that blood is coming from the glomerulus, that would be squeezed, and that would give you the form of dysmorphic, deformed RBCs, which you would see under the microscope. So if under the microscope you just see normal RBCs, like you see some over here, so if all were normal, then probably it was of non-glomerular origin. But if you find like so many RBCs which have been deformed, then it simply means that they have been squeezed. How they can be squeezed? They can be squeezed when they pass through the glomerulus, when they've been pushed through that tight structure. So if you see dysmorphic or deformed RBCs, that means that blood is coming from the what? Glomerulus. Number one. Number two is the presence of RBC scars. So if you look at this particular side, so what you can see is that there is an elongated structure in which the RBCs have been clumped together. They have been clumped together. So when these RBCs, damaged RBC, let's say when there is problem with the glomerulus and these RBCs have been squished and pushed through the glomerulus, as they are passing through the renal tubule, the proximal tubule, what would happen? These damaged RBCs would be stacked on top of one another, and a sort of a rectangular elongated structure is formed. by clumping of these RBCs together, and we call them as RBC cast. So RBC cast simply means that the red blood cells have been squeezed, pushed together from the glomerulus, so in such a way that they've been stacked on top of one another. So the presence of RBC casts presence of the RBC casts, that actually tells you that that blood is of what? Glomerular region. Okay, moving on. Now coming to, excuse me. Now coming to, as I told you, that hematuria basically is classified into two types, either of glomerular origin or of non-glomerular origin. So here in this slide, you see we have got that path. So because initially we were not sure where this hematuria was coming from, but because of the deformed RBCs and because of the RBC casts, in this particular case, we know that it is of glomerular origin. Their blood could be of non-glomerular origin as well, which I told you. It could be in the reason could be beyond the kidney, especially the non-glomerular part, like it could be in the form of pyelonephritis, which is infection of the renal cells. It could be the renal mass, like it could be polycystic, or maybe some arteriovenous malformation. There could be causes in the ureter, like a urinary stone, a ureteric stone, maybe some malignancy, a stricture, or maybe a polyp in the ureter. It could be causing the bladder, like for example a bladder stone or infection in the bladder, or an malignancy or radiation cystitis. Or there could be other reasons, which could be like, for example, prostatic issues, urethral issues, or maybe coagulation defects, etc., etc. But in our case, because the RBCs are deformed, excuse me, I've got a sore throat as well. Because the blood is of glomerular origin, so the problem is in the glomerulus. So most probably glomerular origin hematuria is caused by glomerulonephritis, which is the most common cause of hematuria. And again, it's an umbrella term. Glomerulonephritis could be of different types. But anyhow, here so far we know that this patient has got hematuria of what? Of glomerular origin. Okay, moving on. How we further look into glomerular disease. Glomerular disease, okay, can present in two forms. Either it can present in a nephrotic form, or it can present in a nephritic form. In nephrotic form, the basic issue is what we call as nephrotic range proteinuria. So basically, instead of hematuria, the problem is what? Proteinuria. So the damage to the glomerulus is such that instead of blood, it is passing mostly what? Proteins, albumin, and like some other proteins as well. So proteinuria, if that is the main issue with glomerular disease, we call it like nephrotic range problems or nephrotic syndrome. Or it could be mainly the presence of blood. So it's like hematuria, where we call it as what? As nephritic syndrome. And that can be in the form of glomerulonephritis again. And again, glomerulonephritis can be classified based on the presence of certain, sort of what you call underlying pathologies, which can actually be detected by certain tests. And these are like, for example, some form of glomerulonephritis may be associated with positive anti-neutrophilic cytoplasmic antibodies. Some of them might be associated with positive anti-glomerular basement membrane antibodies. Some of them might be associated with the decrease in C3 and C4 levels. And there could be other ones which can be associated like with, for example, ASO, high ASO titers, the presence of anti-nuclear antibodies, or the presence of anti-DNAs B. So we have to do different tests in order to further classify which type of glomerulonephritis is there. But again, these tests are very expensive, and usually there's a high cost of doing all these tests simultaneously. So basically, we'd start with history and physical examination, because history and physical examination would guide us whether we should go for some like preliminary screening tests. Like for example, if somebody is showing rashes or features of SLE, we might go start with anti-nuclear antibodies. If somebody is showing signs of sore throat or something, we might start with ASO titers, so on and so forth. So we look basically at the findings in the physical examination and what we found in the history, and then we would be ordering different types of tests depending on what we find, rather than blankly ordering all these particular tests. So let's revisit the exam. with the skin lesion. So if you, again, let me show you the skin lesions once again. Again, if you look at these skin lesions, so basically these are painful skin lesions which are well circumscribed, has got a central area of scab formation or eschar formation, and you can see some, like, clear pussy material coming from below the eschar. And obviously everybody would understand this is what we call as ecthyma. So ecthyma basically is a skin infection, and it's a superficial skin infection which is caused by Streptococcus pyogenes, especially the nephrogenic strains of the Streptococcus pyogenes, and it causes superficial skin infection. So there is a bit of, like, pus formation, and on top there is scab formation, eschar formation, and beneath that you will find there is superficial inflammation and pus formation, which is known as ecthyma. So this is basically ecthyma, which is a skin lesion caused by what? Streptococcus pyogenes, S pyogenes, and usually the strains are nephrogenic. And here we know that streptococcal pyogenes skin infection or throat infection, especially if it is caused by nephrogenic strains, can cause renal disease in the form of what we call as post-streptococcal glomerulonephritis. Yes, so our patient has got post-streptococcal glomerulonephritis. Why? We did some lab tests and we found out that his ASO titers were 1267. Anti-streptococcal lysine O titers were 1200. Normally they should be less than 250, but or some labs use the cutoff levels of 200 as well. But here, like you see, it's very high, very, very high. So this means that he has got streptococcal infection. Similarly, we did the complement level, the C3 and the C4, and you can see that the C3 and the C4 levels are down. Normally, I mean, they're quite expensive, so I think I would simply go with C3 level, so a low level of C3. Normally here you can see it is 40, normally is like somewhere between 80 to 200. Similarly for C4, it is quite low. So low C3 levels and high ASO titers, obviously this goes in favor of what we call as post-streptococcal glomerulonephritis. So this child, 13-year-old, is suffering from what? Post-streptococcal glomerulonephritis caused by streptococcal skin infection. Sometimes the ASO titers might be normal. So if that is normal, then probably you have to do, later on, you have to do the anti-DNase B test as well. Anyhow, but most of the time the ASO titers would be, especially if the illness has been going on for, like, let's say 2-3 weeks, but maybe in the early phases they might be normal. You might have to repeat it after some time, but the complement levels would be down. So that actually clarifies that this is a case of post-streptococcal glomerulonephritis caused by nephrogenic strains of Streptococcus pyogenes causing a skin infection known as ecthyma. Okay, now coming down to the treatment of this type of post-streptococcal glomerulonephritis. So certain countries, they use benzathine penicillin for post-streptococcal glomerulonephritis with or without cardiac involvement. But here in UK, we just use oral penicillin for 10 days. So usually it is supportive treatment. So we give them what? Oral penicillin. So phenoxymethyl penicillin, I think up to age of 6 years, we give 125 milligram QDS for 10 days. This is up less than 6. Between 6 to 12, we give them 250 milligram QDS orally for 10 days. And greater than 12 years, we give them 500 milligram QDS into 10 days. So in this case, because he's 13-year-old, he would be having what? 500 milligram QDS for 10 days. So this is usually the standard treatment for post-streptococcal glomerulonephritis. But we have to look into other conditions as well if there is a renal involvement, and especially we have to check the blood pressure as well, because with kidney you can know that the blood pressure can rise, and if the blood pressure has risen, then you have to control the blood pressure. So strict fluid balance is very important so that the child doesn't go in a negative or in a positive fluid balance. And for that, we have to maintain the input and the output, so we know what is going in and what is coming out. Or if the blood pressure is raised, then we have to give them medications like nifedipine or amlodipine. So we use them vasodilators like nifedipine or amlodipine. Remember, don't use ACE inhibitors or beta blockers. ACE inhibitors, they don't work. Beta blockers can, the ACE inhibitors can cause like hyperkalemia. So that's why, I mean, they shouldn't be used. Beta blockers are also not recommended for acute post-streptococcal glomerular nephritis. So if the blood pressure is raised, either you will be using nifedipine or amlodipine. So please keep this thing in mind. Don't use ACE inhibitors or beta blockers. They also need review. So the review is done like at 1 to 2 weeks, and 3 to 4 weeks, and 6 to 8 weeks, and then at 3 months interval. So at every review, you check their blood pressure, you check their urine for presence of proteinuria, for presence of hematuria, and things like that. And at 3 months, you would also repeat their C3 levels. You have to see if the C3 levels have come back to normal level or not. So because if the C3 levels are back to normal at 3 months, then it's fine. You don't need to worry about. But let's say if at 3 months the C3 is still down, then you have to refer them to nephrologist, because then probably they have to do a biopsy and see, because that might lead to another phase of glomerulonephritis, what we call as membranoproliferative glomerular. So membranoproliferative is the proliferation of this inflammation. So C3 has got a prognostic level. So C3 at the time of diagnosis, and then it is repeated at 3 month intervals. At 3 months, it should be normal. If it is not normal, you refer them what? To nephrologist. Remember, microscopic hematuria, if like blood is still present, like that's 3 months or 6 months, you don't worry about that, because microscopic hematuria may continue up to 2 years. You need to tell them that this blood presence in urine may go up to what? Up to 2 years. Yes, blood pressure, if it is raised, you have to continue these like medications to control the blood pressure. So remember, proteinuria is more important. If presence of proteinuria, or if the C3 levels are still low at 3 months, then you have to refer them to nephrologist. Otherwise, microscopic hematuria would persist for up to 2 years. So this is the treatment of post-streptococcal glomerular nephritis, that is penicillin for 10 days, strict input output. If blood pressure is raised, you would be obviously controlling it with medications, and you have to do regular reviews. Obviously, there are so many other things that I didn't mention in this particular thing that you will be doing. So for example, it's not only that you will be looking at ASO titers, you will be doing a full blood count, you will be looking at the coagulation profile, you will be looking at urine electrolytes, because you look at the creatinine and other things to see that the renal function is not compromised. Because the renal function is compromised, then you have to admit them, and obviously you have to like maintain a strict input output. And obviously you need to do an ultrasound, so ultrasound and then repeat ultrasound at some time to see that there's no renal scarring and there is no shrinking of the renal, that the child is not going into chronic glomerulonephritis. So these are the few other things that you'll be doing, but by and large, as far as a specific treatment is concerned, that is oral penicillin for 10 days. I've given you the doses, control blood pressure, and repeat or regular reviews at a couple of weeks, and to see how the child is progressing. And depending on how the situation is emerging, then you can do for the test, or you can refer the child to nephrologist. So this was a short video about post-streptococcal glomerular nephritis, in which we tried to illustrate this with the help of a hypothetical case. I hope you have liked this video, and if you'd like to give me a thumbs up, and if you've got any question, you can put it down in the comment section below, and I will try my level best to answer them as soon as possible. And if you haven't subscribed to my channel, please do subscribe. And have a very good day. Take care, and bye-bye.